All right, guys, good evening. We'll just let everyone kind of pile into the room here. A few people all kind of tune in late. We had loads and loads and loads of you sign up for this session tonight. So I'm just going to give a little bit of time for people to get in, give you a bit of an introduction on myself. But before we do that, let's jump into the chat box for me. Let me know, can you see me? Can you hear me? Can you see the PowerPoint? I just want to make sure we can all hear what's going on. Wonderful. Good. Here we all are. All right. Excellent, excellent, excellent. Good. So hope everyone's doing well. This is kind of our buzz session, really. This is a buzz session because we start July is where the crash course really kind of kicks in. So what we've got is PTA crash course starting now next week. And then 3 weeks after that, we have our PT crash course starting. So this is kind of my buzz session to just to kind of get people excited for the crash course, for you to kind of get access to that and those different things. So for the slides and those things, so the recording of this will be available in the crash course page. Okay, so this is only, and the slides will only be available to people who've actually purchased this the crash course. So if you are wanting to get access to this, you would need to be in the crash course, and then the recording will be there as well. Okay. If some of you are VIPs, you will have access to the crash course when we start that. So don't worry about that. So if you're in the VIP class, you will get that. Also, the people in the PTA premium will also get full access to the recordings, the slides. They'll all be over in the crash course folder. Okay. And once that course opens up, you'll get that. All right. So let me just give a little bit of an introduction on myself. My name's Mark Stevens. I am a physical therapist. I am not originally from here, from England originally, and been out here in the States now for approximately, what's it been, 9 years now, 2013. So my clinical journey, I started my career as a PTA in the UK. I worked in a neuro outpatient clinic in the UK, worked with neuro, stroke, progressive neurological diseases, and then also worked with amputees at that time as well. From there, then I decided to go back to school and try to qualify and get my full PT license, which I did. In 2012, I graduated from PT school and then moved out here to America in 2013. So I'm currently living in Grand Rapids, Michigan. And I work for a large rehab hospital network here in the Grand Rapids area. I work pretty well. I'm kind of part-time clinical, part-time management alongside the clinic. So I do about 20 to 25 hours clinical work with the patients, and then I do the rest of my work admin, managing a clinic out in the Muskegon area. So that's just kind of about me and my journey. I have been working for PT Final Exam since 2015, taking thousands of students through the board exam, and to get you ready to kind of take the test that's really going to get you through and into licensed therapy world, which is where we all want to be. You are kind of approaching that point now where you're going to actually get paid to be in the clinic, rather than you paying to be in the clinic to do the job of your CI. So that's kind of a joke that I kind of say to students that we have in with us, is like, all right, soon you'll be getting paid rather than being paid to be paying us to be here. So that's a bit about my journey. So a little bit about, I'm quite a handsy teacher. So when I do present, I'm quite handy. So I'm just going to point out my hand. First of all, I had surgery yesterday when I tore my TFC this winter, trying to be a cool dad. My son asked me if I could do this jump that he saw a few other kids doing while we were going up the ski lift. And I was like, all right, hold my beer. No, I couldn't do it. So I tore my TFC, messed up a few things in my hand. So I had surgery yesterday to kind of fix that up. So you can kind of see I'm still kind of a little bit orange from the iodine. My daughter painted my fingernails to make me feel better. So that's from there. Okay. All right. So if you, how do you know if you're a VIP? All right. So if you're a VIP, you have signed up to the VIP class. All right. That is Will's premium class that he runs, and you would have been in that for the last few weeks. So if you don't know you're a VIP, you are not in the VIP class. Okay, so that's one of our longer, more robust classes that we do here at PT Final Exam. Okay. All right, so let's talk about the crash course first. I'm going to talk about the crash course before I give you my amputee content, because I really want to talk about the course. This is what the free session's about, kind of this buzz for the crash course. Okay, so what we've got is kind of highlighting the PTA crash course. PT is very, very much the same, okay? But I've highlighted the PTA because the PTA class starts Monday, all right? So what we've got, 3-week class, 3 systems, 12 live lectures, and then we have this private Telegram app for peer support while we're going through. So this is the breakdown of our course. So the crash course is a very, very fast-paced, very robust class going over the biggest systems that you're going to cover within the exam. So within the exam, the big 3, we call them, are musculoskeletal, neuro, cardio. They are going to take up the vast majority of your test. So what we're doing while we're going through things, we want to make sure that you are focusing a lot of your study on the things that are going to come up the most. So what we've done over the last few years, students have been asking us to develop a class that is fast-paced, that doesn't take very long, and that's relatively cheap. Okay, so that's what we've done. And we were like, the best way we can do this is to focus on the big 3 systems, cover that, and then go from there. So musculoskeletal in week 1, neuro, and then on to cardio. Each week is going to consist of 4 live lectures where we will go over, for the PTAs, we will go over data collection, diseases and conditions that impact effective treatment, interventions, and then we have a practice question session. The PT class, then we do flip it a little bit and we do the examination, differential diagnosis, interventions, and practice questions. So there's a slight difference between the beginning 2 sections of both of your exams. So that's what we really want to focus on while we're doing it. Okay, so let me do a quick poll here. First of all, I just want to see where we're at for who's here. So are you a PTA? Are you a PT? All right. Just give you like 30 seconds to go through this. Everyone get your answers in. So we've got, okay, so we're about 75% PT in here, about 25% PTA. That's great. So let's end that poll and let's launch another one real quick. When do you sit for boards? So let's go here. Well, let's launch this one. When do you guys sit? Are you July 22 exam coming up? October, January next year? Usually for these kind of sessions, most people are aiming for this this July exam. So yeah, we've got a good, let's share that result. So we've got a good 84% of people who are going in for this July exam. So I'm really, really excited and glad you guys are in here for the course. So next question that I want to ask you then, have you signed up for the crash course? So who's already signed up for the crash course? Who's signed up? Who hasn't signed up yet, but is planning on signing up? Who hasn't signed up? And going from there. So we just got a good idea of what we're looking at. Okay. All right. So as you're moving on, for those people who are sitting in October, sitting in January, there are some really, really good group discounts that you can get if you're early enough. So as you're getting ready for your exam, shoot me an email, mark@PT-Final-Exam. I'll post that after as well. And you guys can send me an email and we can kind of get a big group of you in together, and you can have a pretty good discount for that as well if you go in as a group. Okay. All right. And then my last question, who in here is from our VIP class? Who in here is from PTA Premium, and who is in the PT Premium class? Okay, so we're around 50 people in here who are already in some of our courses. So what have we got? If we focus on the question they hear, if we focus on the crash course, our chances are good on passing. So the crash course is it's a review. It's a big review of the big systems. Now, if you are just starting your studying 3 weeks out from the exam, no, you don't stand a good chance of passing. Okay. If you are already studying, you've already been diving into a lot of the content, then yes, the crash course is a really great option for you, because it's going to give you a boost of those big systems. It's going to be a boost of those big systems as you're moving through towards the test. Okay, so you really need to have been studying already. For the PTs, if you haven't started studying, you need to get on it right now, because you guys are about 6 weeks out. PTAs, you're just coming up to just the end, 3 weeks out now, I think, three and a half weeks. So you really want to have been studying already. The crash course is a really good last minute push to get you over the line. Okay, so that's what we're looking at for there. All right, so a couple of questions here. Is the crash course similar to the independent course? No. The crash course just focuses on the big three systems. The independent course is pretty much all of our, it's like a lot of our material and our videos pre-recorded, but you've really got to go through this self-paced. So it goes through some of the similar content, but the great thing about the crash course is that it is live. Okay, everything's live. You have the lecturers there. We go through the sessions and you can actually ask questions as we're going through things. You've also got a really big group of people taking the course with you, so you are able to kind of go through the class. If you're in the independent class already, you can get a discount, so you can get into the crash course for $99. So anyone who's in the VIP, anyone who's in the PT premium or PTA premium, you get free access to the crash course, so you will you'll be covered from there. Independent class, you would have to sign up, but you can get a discount on that. All right. Okay, good. So that's any more questions on the crash course. One other thing within the crash course, then we do include these pre-recorded modules. So pre-recorded modules on gait, integumentary, non-systems, and lymphatics. So within the big three, musculoskeletal, cardio, neuro, that is going to be the biggest portion of the exam. Non-systems is pretty much the big cousin of the big three. If you've got the big cousin of the big three, if you are really good in non-systems, you are someone who's going to pass this test really well. The people who are really strong at neuro, cardio, musculoskeletal, and non-systems are the people that are really pushing those high scores. Okay, so if you are weak in one of those areas, you want to do all you can to boost that area up. Okay, you could get all of the questions right in cardio, musculoskeletal, neuro, and pass the test and not get a single other question right. But if you think about the test in itself, you've got probably about 50, 60 questions in the musculoskeletal system. You have 3 for GIGU. So you can see like where you should be studying, bang for buck. If you want to be studying at any point, you want to make sure you are focusing on the stuff that's going to get asked the most, especially if you are limited on time. Okay, so focus on those big areas that are going to get you the most points. Musculoskeletal, cardio, neuro, non-systems. Okay. All right, so we can ask a few more questions about the crash course at the end and go through there, but I know everyone's tuned in because they want to get some content about prosthetics. Okay, so prosthetics, this is my jam. I love prosthetics. This is pretty much I would say this is my clinical specialty. Within my caseload, I think I see probably about 70% of my caseload is amputee. And they vary from pediatrics up to geriatrics. So people have lost legs due to trauma. People have lost legs due to diabetes and wounds. People who have lost legs due to cardiovascular issues. That is kind of what I do. So every day I'm seeing a few amputees. So and I love it. Absolutely love working with amputees. They're a really fun group to work with. So as far as the test goes, you've got to think about a few different things that may come up. One thing that you want to be aware of is amputee levels. Okay, so what level is your amputation? More often than not, they're going to be asking you questions amputee wise around the lower extremity. You're not going to get many questions about the upper extremity. I feel like the upper extremity is going to be a little bit more focused for OT, when PT are going to focus more on the lower extremity. So as far as your amputee levels, these are the ones that are going to come up the most. Okay, so these are the ones you'll see the most. These are the ones that that are there. There's a couple others in there as well, but we won't talk about those too much. So you've got a transmet first. So anytime it's trans something, that's where it's cutting through. Okay, so a transmet cuts through the metatarsals. A show parts, okay, show parts is going to be a little bit higher. Then you've got your cymes. Okay, so your cymes is again going to be up a little bit higher. Cymes pretty much takes the foot off. All right, takes the foot off, still leaves the end of the, leaves the, pretty much take it away from the talus. Transtibial then through the tibia, knee disarticulation, you go right through the knee joint. Transfemoral through the femur, hip disarticulation, take the leg off, keep the pelvis there. Hemipelvectomy is where they take half of the pelvis away as well. Okay, so there is multiple different levels, multiple different things that need to come in with that. Now, if you're someone that likes words and looking at various things, then that last slide would have been great for you. But if you're someone who likes to see it as different areas, especially, I think the leg is pretty straightforward: trans-tib, knee disartic, transfem, hip disartic. You know where they are. It's the foot ones that get a little bit confused and a little bit stuck. So toe amputation, obvious. And then you got metatarsalophalangeal, transmet, Lisfranc. Okay, so the Lisfranc is where they kind of just take the metatarsals away. They leave then the foot bones. Show parts, like we just talked about. So that's where they take away the majority of the foot bones, but they leave the calcaneus structure. Calcaneus and talus is left there. And then the cymes is where they take away the talus and the calcaneus as well. So that's going to be the different foot levels that you might see more commonly with your amputees. Okay. Who here has worked with amputees before? Just by a show of hands. Not many people. A few people. All right, so we got a few people. Good. They're my favorite. They're so much fun. All right. So here are the leg levels. Okay, so like we say, foot amputations, trans tibs, knee, transfem, hip disartics. All right, so after we've got the levels lined up and the levels kind of there, and you've got those figured out, then we start to need to think about, okay, what's happening with the socket? All right, what socket have we got? What are we trying to do to maintain the leg on the leg? Okay, so on the residual limb, where are you going to go for that? So you've got a few different things. So whenever we're talking sockets, whenever we're talking about suspension, we've got to be thinking about, is it transfemoral or transtibial? Because they're all going to be just a little bit different. Okay, so let's talk transfemoral first. Over here, we've got the transfemoral. What we have with that is you've either got ischial containment or subischial containment. So what they mean by that is, does the prosthetic or the socket here, does it have a bit of ischial containment? If it's got ischial containment, what they do is they kind of flare the top of the prosthetic out, and basically the patient can sit right on that, or the prosthetic can sit on their ischial tuberosity. And that's going to be a really good spot for the patient to be like, yep, my leg's in the right spot. Yep, it's in the right way. If they're not quite getting contact, then they might be sitting up a little bit high in their leg. They may have too many socks on. They might not be able to really get good contact with that. Then you do also get a subischial containment. Now, subischial containment, they're going to be a little bit more tricky. You need to be a bit further along your prosthetic journey. And the reason for that is within the first 12 months of becoming an amputee is when you have the biggest amount of volume change. So you go from having this normal sized leg to all of a sudden you cut away and you lose distal attachments of certain muscles and they atrophy. They atrophy, they get smaller, they get smaller, they get smaller. And what you do over the first 12 months is that leg just gets smaller and smaller and smaller and narrower and narrower and narrower. And then you have to do a bunch of different things with maintaining sock ply, maintaining the correct fit. Now, if you've got subischial containment, one, you need kind of a suction device to be able to keep that on. And if you have too much fluctuation in volume, then you can have difficulty with getting that leg to stay where it needs to. The other thing then with the subischial containment is you have to be really, really strong around your pelvis. Okay. What you have with the ischial containment is you've got somewhere to kind of rest that prosthetic on, and they can kind of sit on that. And that sit bone can really compensate for a lot of weakness. If you don't, and you just have that leg holding on there, then you've got to maintain a lot of your hip positions. You've got to maintain a lot of that independently. Okay. So somebody who's got a hip flexion contracture would not be a great, would not be a great candidate for a subischial containment. You'll often see these subischials with people who are a little bit younger because they're going to have better control. Okay. So they're the two different types of transfemoral. like sockets, and then your transtibial, you've got a few different options for transtibials. Now, what you've got your patella tendon bearing socket, which is going to be your most common, most popular one you'll see. Then you will see the supracondylar patella tendon, okay? And then you've got your supracondylar suprapatella. Now, what have we got here? So a supracondylar suprapatella is, let me grab a pen real quick, is going to be, so this picture here is a supracondylar suprapatella. And what that means is it comes up above the condyles and it comes up towards the top of the patella. Okay. Now, if you've got a supracondylar patella tendon, this is going to come a little bit lower. All right. But you're going to get higher around here. So this is going to maintain high, but you're going to have a lower option there. And then you're still going to get that real big weight bearing area right here on that patella tendon. So that's the difference between the two. So if it's got supra, then it's going to be above. Okay. Supracondylar, suprapatella, supracondylar patella tendon. But the most common one you'll see is going to be this patella tendon bearing socket. Okay. So it comes down a little bit lower, sits around, kind of around here and to about there. And we'd go from there. And then I always get a lot of questions on, okay, well, why, how do they choose? How do they choose what someone's going to go into? How do they decide on those different things? Now, the shorter the residual limb, the higher your like contact really needs to be. Because if you think about this one, for instance, this is a really short residual limb. So if you are coming down quite low and you are there, you just don't have as much contact or contact places that you can go into to allow them to get really good comfort when they're in the leg. So if you've got the ability to come up a little bit higher to kind of grip onto the condyles or come up around the patella, then you can have a little bit extra contact. If you are unable to do that and the patient can't really get good fit, then they sometimes have to do what's called a joint and corset, which patients don't love, because in that case, you might as well be an above knee amputee, because it pretty much locks that knee out, makes it where they've got a strap that comes up above the knee, secures it onto that thigh, which takes a little bit of the weight bearing and the forces into different spots. So that's what they do with that. And that's just really how that works. Okay. Can you repeat that? The smaller limb? Yes. So if you have got someone who's got a short residual limb, okay. So if you've got a short residual limb, so maybe if you've got like, I don't know, 6 to 6 inches maybe below the knee, then there's just not really much for that prosthetic to grab onto. Okay. So the shorter the limb, the kind of the higher the socket needs to be able, because the most comfortable prosthetics are the ones that get the most contact with skin. Okay. So they get the most contact. They got as much stuff to grab onto as you can. So that's just what we're looking at from that side. Okay. So yeah, if anyone's got any questions as we're going through, please throw them in the chat box, throw them in the Q&A box. I've got both of them open. So I can answer those for you as we're going along. Okay. All right. So that's going to be a different types of socket. The next thing that might come up on a question could be related to suspension. So what they mean by suspension is, how does the leg stay on? Okay. How do they keep the leg on? Now, for a transfemoral, there's two real options for that. And that's going to be a suction or a lanyard. Okay. So this picture here on the right is a lanyard. Now, what they do with that, you've all seen so you can just see the liner on this patient. So you can see the liner. They put the liner on first. Now with a lanyard, they kind of have this strap. So this strap here, they have that sticking off the end of the liner. Okay. As they put their leg into the prosthetic, they feed the lanyard out of this hole. And once they fed it out of the hole, they go and they tuck it up through this hook, and they they pull it up and they snug it down. Once they snug it down, they can really then get seated into the prosthetic. Now, this is a really good option for someone who maybe is a little bit older, someone who maybe doesn't have someone who's got quite a lot of volume change is going to be good in a lanyard. Somebody who maybe doesn't have much strength, someone who's maybe got poor hand dexterity, they may be more beneficial in a lanyard. Okay. And then with your suction, basically what you do from there, the same liner you've got, you have this ring of rubber that is around the liner. And then they spray alcohol spray on that. That makes it reduces the friction, allows them to slide into the socket, and then it dries really quick. And then as soon as they kind of pull out, they don't lose suction. So what you've got at the bottom is this little valve, which is a one-way suction valve. Okay, and it's kind of located down in this area. They've got this suction valve, and basically they go push down into the prosthetic. A load of air escapes out of here. Okay. And then it's one way, so air can't get back in. So as soon as they pull back up, that rubber is sealed on, their suction is in place, and they're good. So then when they're taking it off, they either have to push this button on here to release the valve or unscrew that to take that out. And that's how suction is going to work. The problem with suction is you need to be able to maintain volume. Okay. If you're having loads of volume fluctuation, then you're just going to lose suction all the time. So they don't. Occasionally they'll put someone in a suction right off the bat, but other times they will opt for a lanyard. Once their volume's down, then they'll go for that. So question there. So the shorter the residual limb, the higher the prosthetic and the more contact is needed. Correct. All right. So the suspension with the below knee, so the transtibial, you've got these options. You've got a sleeve, you've got a pin, and again, you've got suction. So the same way the suction works for the above knee, you've got this valve that's in place. You push down, air escapes. Once you pull back, the suction is formed, the leg stays on. With a sleeve, okay, this is basically just like a neoprene sleeve that's over this bit of the prosthetic. They slide their leg into it, they get it settled, get it in good spot, and then they roll the liner up. The liner neoprene comes over just like a knee brace, and it holds that leg on. Okay, so that's another one. The fit is really nice. A lot of people like these. And then you've also got a pin. So this picture here is someone with a pin. All right, so you've got this pin that sticks off the end of the liner. There's a bunch of it's like a screw basically. It's a ratchet. And then as soon as they put it into the prosthetic, there's a hole at the bottom. They push down, it'll go click, 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 and it's secure. The only way then they can get it off is to push this button on the side. They push the button, it releases that pin, and then they can take their leg off. Okay. Really, really common pins. Okay. So they're really nice. And originally when people put them on, they hate them because they have a hard time getting that pin to line up where it wants to go. Sometimes it'll be pointing forward, sometimes it'll be off to the sides, and then they just cannot find the ratchet for it to lock in. Okay, so they are your different types of suspension. So when you've got questions coming up on boards, it might say something like, you've got a new amputee who is just about to start prosthetic training. It might say that they're a transtibial amputee. They have got CHF. They've got like increased edema, and going through those different things. So increased edema, CHF. They might say what is going to be the most appropriate like suspension for this patient. Okay, so in that situation, I'll ask you guys, what is the most appropriate suspension for a transtibial amputee who is going into their first prosthetic? Not a suction, correct. Sleeve could be, possibly a sleeve, but I'm more than likely going to go for a pin, okay? Because even if you have volume change, even if you shrink a little bit, once that pin is locked in, that pin is locked in, all right? So a lot of people will have a combination, pin and a sleeve, all right? Just as that like secondary thing, all right? So really common for new amputees to have a pin, and that will be the first thing. And then once they've had a bunch of volume change, they've shrunk down, then they might get to a point where they're saying, all right, you're not shrinking much. Let's see if we can get you into a suction and be a little bit more, it just makes things a little bit easier. Some people are just like, no, I like my pin, keep me on that, and you go from there. Okay. All right, so that's your different types of suspension. All right, so that's the big things that we're talking about when we're looking at suspension, when we're looking at sockets. Is going to be there. My internet cut out. Did you say transfemoral for the scenario? I said transtibial, but we could talk transfemoral. So let's talk about transfemoral. If you had the same patient, CHF, lots of edema, like what suspension would you put them in for an above knee? Lanyard. Every day, I'd put them in lanyard. Good. All right. Excellent. So once we've done that, and we're then talking about, okay, for a below knee, for instance, the big things we've got to think about is suspension. We've got to think about functional activities. You've got to think about all of those different things. Then you can start to think about the different types of feet. And I can talk about feet a little bit in a few, I'll talk about feet in the next slide. But the other thing then, above knee, if you've got an above knee amputee, then you've got to think about what knee they're going to get. Okay, so you got a few different options for knees. Now, knees, for me as a therapist, are super frustrating because depending on your insurance is going to have a huge impact on what kind of knee you get. All right. So these are the few different types of knees. Okay, so you've got friction. You've got friction mechanisms, basically. So you've got a locked knee, you've got a mechanical knee, you've got a piston, or you've got a microprocessor. Okay. So a locked knee is what it says. The locked ones look just like this. So the locked ones and the mechanical ones look the same. So they look the same. They look just like this. All right. So they've got this really basic hinge that goes into there. What it's got some stance control with it. So what that means is when you've got contact on the leg, once you put heel contact, then that knee does lock out. Okay. It locks out and it will only buckle then when you unload that and you get toe contact. So once you get toe contact and you come off, then it will swing a little bit and it will be able to go back into heel contact, lock out, give you some stability. If it's a locked knee, that's for someone who's going to be really, really high risk, someone who's going to be high risk of buckling, falling, anything like that. So if you've got someone who has got a locked knee, that knee is going to be locked all the time. So think about the gait pattern you're going to have to do with someone who's got a locked knee. You're going to have to walk with like a circumducted gait or a hip hike because you've got to be able to still clear that foot as you're going through. Once you've got ones that do swing and the mechanical knee and they get a bit of free friction and they can go, then you can have you can have better just better gait mechanics with that. The better the knee gets, then down to the pistons. So the pistons, you can have more control on how fast or slow the knee bends or straightens. You can also have a bit of control with sitting down. You can have some control when you're going downstairs, for instance. They can put, if you get some different kinds of load on them, that knee can bend slowly, which allows you to slowly lower down the stairs. Then you've also then jump up to those microprocessors. So the microprocessors are the ones that have got the computer in the knee. They're so smart. They're incredible. They just give the ability of the patient to do so much with them. So makes ramps easier, makes stairs easier, makes just normal gait just look way smoother. So I've got a patient recently that's just gone from one knee onto a microprocessor, and instantly his gait looks so much smoother, so much better. So much so that on the first session of him getting the new knee, we started to try and see if we could do a little bit of running, which was like amazing to do that. Because the old knee, we'd kind of pushed it to its capabilities and maxed it out. And then we're now on to a position where we can push him a little bit further. Okay. All right. I had a question here in the Q&A box. So let's go. In the real world, are PTs making these decisions? That's a really good question. So in the real world, are PTs making this decision? So in my world, partly. So what we do, if you are involved with amputees and you are involved in a kind of organization or a clinic or anything like that, like I do, where we do a lot with amputees. So we're linked with a large rehab hospital. And within our area, we have myself, who's the amputee therapist. We have our PM&R doctor, so our physiatrist, and then we've also got a prosthetist who we all work really closely together. So we run an amputee clinic, and within that clinic, then we will bring someone in who post-amputation. We will assess them. I'll assess them from a therapy point of view, kind of see pre-morbid condition, what they want to be able to do, what they could do, and we decide their K level. Okay, so what you're doing with K level, the higher the K level, the more functional they are. Okay, so if you're a K1, you're not really doing much. Okay, so you maybe transfers, a little bit of activity. K2, you're probably walking around with a walker, maybe a cane. The big thing that distinguishes someone from a K2 to a K3 is the ability to vary their cadence. So if you've got someone that can then vary their cadence, who can walk fast, walk slow, can be off a walking device, then they're moving up to that K3 level. If you are able then to do high level activities, so running, like sports, if you can do all of those things, then you're pushing K4 levels. Okay. So depending on that, then comes into, if I assess someone and it comes out that I'm like, yeah, this person's a K3, then I can start applying to insurance for K3 components. So I can request a microprocessor knee. Like, I'm never going to get a microprocessor knee for a K1 or a K2 even. Okay. They've got to be, have the potential to be much better. Okay. And then a question here, is micro more likely for younger patients since they are more likely to be more active? Not necessarily. A lot of it comes down to, like I just mentioned, the K level. And the other thing that comes into is their pre-morbid condition, and also their potential for doing something else. So like the guy we just put into a microprocessor in my clinic, he's 56, but he's still really active. He was mountain biking before, hiking, all of those things. So you've got this really active person. So the age doesn't necessarily make much difference. It all depends on what they did. Traumatic patients, so people who were more active before, they are more likely to get higher level components because of how active they were before. But excuse me, there are other avenues as well. So this picture here is, this is the top of the line. This is the Rolls Royce of prosthetics. So this is an Otterbach X3. Who wants to take a punt at how expensive this is without Googling it? 100K, 60K, $140,000 for that knee. So there's not many insurances, seriously close. So there's not many insurances that are going to cover this leg. Okay. So the insurances that will cover it, auto will often cover it. Workers' comp will often cover it. But if you've got your standard Medicare, Medicaid, if you've got just a basic insurance through work or anything like that, then you're in a position where it's, you can push for them. And if you can justify it, great. But otherwise, not. So workers' comp ones, especially if someone has lost their leg and it was the fault of the employer, they've got much better chance of getting these top of the line. So I've got one guy that I worked with, who, young guy, 19, he was working for the city, and he was doing, they're using a wood chipper. Okay. So they were using a wood chipper on the side of the road. And while he was doing some stuff, a car came and hit him while he was putting stuff into the wood chipper, and he lost both of his legs pretty much instantly because he was hit. Now he got workers' comp, and he got 2 of these. All right. So he got 2 X3s. So what are we at? 280 grand. He's got a house basically on his legs. It's unreal. But he's doing phenomenal now. He's up, he's moving, he's running. He's doing some like incredible stuff. So that's what frustrates me about, as a therapist, about that, is there's these incredible knees out there, there's incredible things that are out there for people to use, but it's so determined on is so determined on what the insurance covers and the activity level of the patient and various things like that. Anticipated lifespan of a leg like that, I would say you're probably looking at about 20 years on that. 15 to 20 years, depending on how much you use it. Like if you really beat those things up, you can go through them in 5 to 10. So it also depends on the person. So if you've got time, jump on YouTube and search Otterbach X3 and just watch the promo video for that. And you can just see, you can see on that video why it's as expensive as it is, because it does everything. Okay. It's got stair function, so you can reciprocally climb up steps with those, and it will take you up steps. You can come down steps reciprocally. You can go up and down ramps. You can jump up and down off things. This guy's jumping onto a dock. Otterbach, OTT. My accent. Otterbach X3. All right. Yeah, they can be used for running. People can run on those. So, all right. So let's jump away from knees. Knees are so much fun. They're really fascinating, but let's jump on from there. If anyone's got any more questions, we can answer those at the end as well. All right. So feet. So what are we looking at for feet? We have got the most common one that you'll see during the exam is going to be the satch foot. So the solid ankle, cushioned heel. Okay, solid ankle, cushioned heel. That's going to be the most common one. So this foot here that you can see is a satch foot. Okay, it's pretty solid in the ankle, but this kind of kick out of the back is going to be a bit of a cushion. This is carbon fiber. It's a really nice foot. This one, lots and lots of my patients have got this foot. There are a few different types now. There's a J foot that's basically like a blade, but it's got a heel on it. They're really nice now, so you can run with those. They are a nice day-to-day foot, but also if you are someone that's like, do you know what, I'm going to walk around, but also I might run a little bit, or I might be walking around and I want to go and play golf, or I'm going to be walking around day-to-day and I want to be able to do this. That's going to be nice. There are lots of people who have got, nope, this is my day-to-day foot, and then I've got a sports foot or I've got like a blade for running or something like that. So lots of people have got different things for their needs, but the more things you need, the more you've got to justify it, the more you've got to cover things by insurance and things like that. The other one that's a common that might come up is the stationary attachment flexible endoskeleton. So that is going to be a safe foot. All right. So that's going to be there. Basically it does a similar thing to a satch foot. All right. It's just got these, it's a little bit more flexible on the outside. Okay. The other thing, then you've got single axis foot. What a single axis foot does, it will move in one plane of motion. So usually plantar flexion, dorsiflexion, which allows patients to be a little bit better on things like ramps, uneven surfaces. They can be a little bit more stable with that. But then you've got your multi-axis ones. So the multi-axis ones, they will rock side to side, up and down. So when you're walking around, if you're on off-road terrain, they move for you so you don't feel so uneven. Now with a satch foot, as soon as you go uneven, that foot's throwing you around different places. So people can find it quite uncomfortable on uneven terrain. The only problem is the more things you add to it, so the multi-axis, single axis, you can get microprocessor ankles now as well, which do more. They can give you toe off, they can give you heel strike, they can give you trying to mimic the real foot. The more things they add to it, the heavier it gets. So then you've got people going, oh, this leg's too heavy. I don't like it. I can't do as much as I want to do. So that's that one. So what is the one called that allows the patient to pivot? That allows them to pivot in the sense like on a flat foot or on their toe. Most of them, you should be able to pivot. You've just got to lift your foot in a good position. Most of them. The multi-axis one is going to probably give you the most ability to do it. And then a question here, isn't a satch foot for older or less active individuals? So yes and no. It all depends on the patient. So I've got most of my patients, when they get their first prosthetic, will go into a satch foot. So you go into a satch foot because you want to be able to learn the leg. You want to be able to learn what's going on before you start adding these crazy components, because the more they move, the worse your balance is going to be. So you want to be able to teach someone a lot of how to do things. So either a satch foot is going to go on as their first foot, but then there's also a lot of people who may be a little bit older. They would never graduate from that foot, if that makes sense. So most people go into a satch foot first, and then they progress from that. All right. So the other big thing that I want to talk about with prosthetics is pressure sensitive areas and pressure tolerant areas. So loads and loads of questions come up around this throughout all the practice tests and various things like that. So what they do is they'll ask you questions about, okay, so you got an amputee that you're working with, you remove the prosthetic, and as you remove the prosthetic, the patient has got a red area over the fibula head. Is this a normal? Is this a spot, or where would you expect to see normal weight bearing pressure sensitive areas? So it's looking for you to be able to point out what areas of the leg should be red and what areas of the leg shouldn't be red when you're working with this. Now, this can get a little bit confusing, but the easiest way to think about it is if you have got a spot on your leg that is really bony, that doesn't have much flesh, doesn't have much muscle around it, that is a pressure sensitive area. Okay. So you can see on here, patella, femoral condyles, your tibial tuberosity, distal tib, fibula head. They are all areas that you really don't want a lot of contact. Okay. Because if you have a lot of contact in these areas, it's going to be super uncomfortable. That's when skin's going to break down. That's when it's going to be having a hard time. So when the prosthetists make the leg, they really design these legs well to be able to have the most contact and the most pressure in these pressure tolerant areas. So these are your fleshy spots, the bits that have got a lot of like cushion there to be able to hold it. So on the, what you're looking at from that is going to be down here on the either side of the tibia. Okay, so either side of the tibia, you've got those fleshy spots. That's the spot that you're going to see redness when you take it off. Here on that lateral aspect next to the fib, that's going to have a lot of redness there. Okay, I don't know. I'm trying to control my mouse with my bad arm, and it's not working. So then around the back, so the big areas you want, your big fleshy spots. If you've got big fleshy spots, that is where you want pressure. If you have got bony spots, you do not want pressure in those spots. So that's the big thing for those questions. Think about your landmarks, think about your anatomy, think about the stuff that's bony, think about the stuff that's fleshy. They are the spots that you're going to want to either get pressure on or pressure off. Okay. All right. So got another question there. I think I listened to a podcast about such soft or rigid cushion implication on gait. Would you mind touching on that? I can touch on that. So what we've got, yeah, I can touch on it real quick. So let me do that at the end. I'll come back to it. Okay. I'll come back to it. Let's stick on this for a second. Otherwise I'll get myself confused. So Abby has asked, our job is to look to make sure those pressure sensitive areas are not red to ensure the prosthesis is fitting correctly. Yeah, right. And as a therapist, what you're doing is if you've got the prosthetic that's not fitting well, or the patient's saying, oh, I'm really tender on the underside of my patella, then you can think about, okay, well, why they got pressure on the underside of their patella? What probably happened in that position is, like, if they're getting pressure right here, what's happening is they may need extra socks. They may be sinking too far into their prosthetic because their pressure loading spot should be right here on the my mind's gone blank. Right here on the patella tendon. So right here on the patella tendon is where you are wanting the pressure. Sometimes if they're sinking too far into there, that patella tendon spot is pushing on the underside of the patella. Same if they are too far up, if they're not getting far enough down into the prosthetic, they might be pushing on their tibial tuberosity. So what you're looking at here is like, right, something's not right, something is right. If they need modifications, they need anything like that, then you can get back on the phone to the prosthetist and say, hey, can we make some changes? Can we adjust a few things on that? All right. Okay. So the other thing then we're starting to look at when we are talking prosthetics is going to be the big thing is gait deviations. Like, can you pick out gait deviations? Can you understand where they're coming from? What is the reason behind it? Okay. So we'll look at a few gait deviations here and try to get that looked at. All right. So another question here, Lisa. If you do note redness, irritation, what is your next step and ultimate cause of action if trying more socks doesn't help? Do you tell them to limit wear until it was resolved? So yeah, it's all gonna depend on what you're seeing. So if you've got someone, say they've come into your clinic, they are complaining that when they walk in and let's say they walk into your clinic and they're saying, I'm really, really tender on my distal tib. You take the prosthetic off and they've got a wound on the end of their distal tib that they didn't realize. What are you going to do in that situation? So for me in that situation, I'm going to be right on the phone to the prosthetist and talk to them. I'm going to be limiting wear time, and I'm going to be saying, there's a reason why you're pushing down. Usually the reason why they've been pushing down too hard is they need socks. All right. So they need more socks, and I can adjust that and I can change that, cover it up, but get them into the prosthetist as soon as I can. Once they get to the prosthetist, then they will then determine whether they should be wearing it, not wearing it, be in the wound clinic, any of those things. So if I find something that I think is bad, if it's bad enough that I'm like, that you should not be wearing that leg, you want to be taking it off and say, do not wear this leg until you have seen your prosthetist. Okay. So that's pretty much what we're looking at, is to be deciding if something needs to be adjusted, something needs to be changed, or if we just need to do more education with the patient. Okay. All right. Another question in the Q&A box. Hand them crutches, maybe, but you could have a pretty frail elderly patient that's just got the prosthetic. They may not be able to tolerate anything without the prosthetic. So in that situation, you put them in a wheelchair, and you're wanting them to be doing that. So that could be one. They're the different things you've just got to think about. All right, another question came up. If you see redness with no wound, can you recommend sock, or do you need to call their prosthetist? I usually do both. One of the things, redness, if it goes away within about 5 minutes, 5-10 minutes, then it's usually it's not been pressure for long. If it stays and hangs out, I'm always sending them back to the prosthetist. Or I take a picture and text it to him. That works too. Okay. Isn't there a rule with sock layers? So there is a rule with sock layers. Great question. So with sock layers, when you're putting that on, what you do, there's different levels, and they basically 1 ply, 3 ply, 5 ply, and you can do a variety of different things. If you have a patient and they get up to 10 ply of socks, then you should be sending them back to the prosthetist, and they will pad them at that point. So they will pad the prosthetic out, and they will bring them back down to a level where they don't need socks anymore. Once they then go back up to 10 ply plus padding, that is usually the time they're ready for a new socket. Okay. So this is all within the first period of the first 12-month period is going to be how you're doing that. So within the first 12 months, some people will have 2 prosthetics or 2 new sockets as you're going through there. So Kelly had a question, 10 layers or 10 socks? So it's layers. So each sock has got a different number. Okay. So you'll have 1 plies, 3 plies, 5 plies, 6 plies. Basically, the patient can layer up as much as they need to. So they can be like, all right, I've got a 1 and a 3 on right now, or I've got a 5 and a 3 on. I've got a 5, a 3, and a 1. And that's just how they kind of work their way up. And that's how you decide how much sock ply layers they're in. Okay, let's show you a walk. Okay, I'm going to show you this one, and you are going to tell me, what is this gait deviation? This was on your exam from year 1. Then I hope you know the answer. Let's show it again. It's not a Trendelenburg. The pelvis is going the wrong way. It is a lateral bend. All right. So this one's a lateral bend. So for a lateral bend, what is the cause of a lateral bend? So if I see this patient walking, what is the cause of this lateral bend? The prosthetic is too short. It could be a medial wall. So yeah, if it's digging into that medial wall, we had a guy in this week that had his prosthetic was digging into his medial wall. Too short, weak abductors, good. So this is what you've got to be thinking about in this situation. You've got to be thinking about prosthetic causes and patient causes, okay? So the prosthetic causes are things that can be changed by the prosthetist. Patient causes, you have to change these, okay? This is stuff you need to work on to make sure it's happening. So what a prosthetist hates is if you see a patient and you send them back to them to make an adjustment to the prosthetic, but it's actually something patient, that really frustrates them, okay? So you want to be making sure that when you're sending someone back or working with them, I work closely enough with my prosthetist that I blame everything on him. But we go prosthetic causes or patient causes, okay? So prosthetic causes, the prosthesis may be too short, improperly fitting, high medial wall, like you all mentioned, or the prosthesis is aligned in abduction, okay? That would also cause one of those leans. The other thing that could cause a lateral lean, poor balance, abduction contracture, short residual limb, weak abductors on the prosthetic side, hypersensitive or painful residual limb. So if something's painful, they're going to limp off it, okay? They're not going to want to be on it for too long. So that is going to be another cause of those lateral bends, okay? Good. All right, let's look at another one. What kind of gait is this? Circumduction. Great. What is the cause of circumduction gait? Too long. Good. So circumduction, too long. Good. Functionally too long leg. Great. So that's what we're looking at. The prosthesis may be too long. The other thing could be there's too much friction in the knee. So the knee's not bending enough. The other thing, it could be that the socket's too small. If the socket's too small, they're not getting down into that prosthetic far enough. The other thing it could be is you've got excessive plantar flexion of the foot. If the foot's excessively plantar flexed, it's kind of like you've got foot drop. So you catch your toe when you're stepping through. Okay, they're clipping their toe, and that could be another reason. Okay, patient causes, abduction contracture, improper fitting, weak hip flexors, adductors, painful anterior distal residual limb, because think about when they're trying to come through into swing phase, they have to bring that hip flexors forward, drive that hip flexor forward. If the hip flexors are weak, they're not going to be able to drive it forward as much. Also, when you drive that hip flexor forward or drive that leg forward, the residual limb hits the front of the socket. So if that is the case, then it can be really painful, really uncomfortable for them as well. All right. And the other one would be that the patient just lacks confidence in the knee. Maybe the knee's buckled out on them occasionally. Maybe they just aren't able to activate swing. Then they're going to have to do these kind of circumduction or hip hiking to be able to get that foot through. Okay. Let's look at this one. All right. Okay. Yeah. So we've got too much knee flexion here. All right. So this is really common. Okay. To have too much knee flexion, that knee just buckles out on people and down they go. All right. You can see this guy when his knee buckles out, he's horrendous. Okay. So weak quads, yes, if it's a below knee amputee. If it's an above knee, obviously you don't have that issue. the things with this one, the socket could be set too far forward in relation to the foot. The foot is set in excessive dorsiflexion, for instance. If they've got a stiff heel, then they can have those issues then as well. All right. So this is where I'm going to talk about the that foot issue, soft heel, stiff heel, or anything like that. Okay. So if you have got someone who has got a stiff heel, okay, what's going to happen is once they get heel contact, okay, they're going to get thrown forward really quick. So they're going to go into heel contact. And then what happens is they go into rapid tibial and anterior tibial translation. So they come heel really rapid forward, and it goes too rapid for the period that knee then buckles out. Okay. Now, if your heel is too soft, once you go into too soft a heel, you put your foot down, it sinks in a little bit more. It causes that foot sinks, and it causes you to have that real brief moment of posterior tibial translation, which is going to then cause hyperextension. All right. So if you have got someone who has got a stiff heel, they're going to have increased knee flexion because it's going to force them into that tibial translation. And if you've got someone who's got a soft heel, it's going to cause them to have posterior, which will then cause knee hyperextension. Okay. Does that make sense? I've got a video on YouTube, all right, on our PT final exam website on YouTube that goes over AFOs, so plantar flexion and dorsiflexion stop. If you go plantar flexion, dorsiflexion stop on PT final exam, go find that video. I talk about the difference between plantar flexion, dorsiflexion stop, the relationship of dorsiflexion and plantar flexion in knee buckling and knee hyperextension. It's exactly the same with amputees. All right. So go over and check that video out. It will really clear up that knee buckling, knee hyperextension in relation to ankle and foot movements. Okay. All right. So did we do? Okay. Let's have a look at this one. So what's this one? So this one's vaulting. All right. So this one's vaulting. What is a cause for vaulting? It's the limb's too long for vaulting. Okay, it's a long limb again. It's the same as circumduction. So circumduction, vaulting, hip hiking, they're all trying to function around that long leg. Okay, so basically they vault in the sense that they go up onto their tippy toe on the good side and they bring that leg through there. So they kind of are forcing that leg to feel shorter. So he kind of goes, if you look, he goes up onto his tippy toe, up onto his tippy toe, up onto his tippy toe to try and get that leg through. All right. So again, good. Decreased knee flexion. It's all going to be all the same side. It's going to be all of the same stuff that is causing vaulting that would be causing any gait deviation for a long leg. Okay. So prosthesis may be too long, inadequate socket suspension, alignment could be, foot in excessive plantar flexion. There's all of those things. Same with the buckling. Is it the same patient with the buckling leg? Yeah, I think it is the same. It is the same patient with that. But this group of videos is just a prosthetist has gone and made a bunch of changes to this guy's leg and said, all right, go walk for me now. All right, go walk for me now. Go walk for me now. And he's kind of made these abnormal gait patterns just for education purposes, which was really helpful. Okay. I know. So I've got a few patients that would do that. I've just got to have the time to get the prosthetist, a patient, videos, and various things like that. All right. So I think we got that. Decreased knee flexion could be a cause. Yeah. Did I not have that written down? Yeah. Decreased knee flexion could be a cause of that. So it's all the same things. All right, now this one's one of my patients, okay? I took this video. All right, so this one's one of my patients. I want you to tell me what is going on with this one. So this is one of those basic hinge knees. All right, this step is the best one to see it. Not a lateral whip, internal rotation, good. So do you see that toe in? He gets this weird toe in. Let's go here. So he gets there and he toes in and kind of internally rotates as he goes into heel strike. And he kind of gets that. So if you've got that rotation at heel strike, so what is that going to be a cause from? If someone's getting rotation of the prosthetic at heel strike, what is that? Contracture, could be contracture. Socket is usually going to be the biggest thing. So the socket's going to be too loose. All right. So you're going to have either excessive toe out is built in, or you're going to have excessive toe in. All right. So sometimes a patient will go into heel strike and they'll rotate out. Sometimes they'll go into heel strike and they'll rotate in. That's going to all depend on what's happening at each point. Okay. So the socket can be fitting quite loose. Inadequate suspension. They might not have enough socks on. That could be that. The other thing it could be is that their heel cushion is too rigid. So they go down and just rocks where they need to go. So they don't have any cushion from that, is going to be from there. Question here. Is there a reason you focused on internal rotation during heel strike? Would there be a different explanation if we saw internal rotation during a different phase? Yes, there would. If you saw internal rotation during a different phase, you'd see a whip. Okay. And that's usually, I won't talk too much because I got whips coming up. So that's in relation to the knee when you got a whip. I focused on the internal rotation during heel strike because that is when you most see that a socket isn't fitting well. So if someone walks into my clinic, walked in and they are rotating in, I'm instantly taking that leg off and putting another sock on. Okay. Seeing if I can get that under control. Is it me or did his step length look really long? Let's have a look. Yep. So what is going to be a reason for someone having a long step length? Overcompensation. What's another reason? Could be the socket's too large. Not going to be the limb too long. Antalgic stance phase. Perfect. So it's going to be either painful, so they don't want to be on that leg. Okay. So that's going to be the reasons that someone has a really short stance time on the prosthetic. So he's got a hugely long stride on his when he's in stance on his good leg. But as soon as he steps onto his prosthetic side, he comes off it really quick. And that's usually going to be, it's going to be a few different things. Pain in the socket, hip flexion contracture, okay, because just think you can't get that adequate hip extension to get into full swing. So it's going to pull them out of that a little bit quicker. But yeah, good spot on that one. Great job. All right, so let's look at this one. What have we got there? Yep, we got a whip. Which one? Do we have a lateral whip or a medial whip? Yeah, so we've got a lateral whip there. Okay, so we've got a lateral whip there. And the how you decide which whip it's going to be is where it goes to first. Okay, so once he goes into toe off, which way does it go? Does it go lateral or does it go medial? That's which whip you've got. All right, so this one, go lateral. So he kicks out. All right, so as soon as he comes off toe, laterally whips out. And that's how you do that. If he was walking and he was whipping in, it would be a medial whip. Okay. What are reasons for whips? All right, so whips are always going to be related to the knee. Okay. So it's very, very much related to the knee. So if the knee's in excessive rotation, if the socket is too tight, then they often don't quite get on right. And if you don't get your alignment right when you put your prosthetic on, then you can rotate the knee by rotating the whole thing. So if you put the leg on and it was rotated slightly, then you could see a whip. And then the other one would be if there was an improper alignment of the toe brake. And the way to adjust the alignment for the toe brake is going to be by adjusting the knee. Okay, so that's what you're going to be going from there. Patient causes for this is going to be improper training. So they haven't been taught how to put the leg on properly. They don't know the key things to look for. Weak hip rotators could be that, because they could have some tightness the other side, which is causing them this rotation at the hip area, which would then make the knee feel weird. And then a knee instability. So if you have got a below knee amputee with a whip, there is nothing the prosthetist can do about it. It's all patient. Okay, so if it's a knee instability, they've got a whip, but they're a below knee amputee, whips always come from the knee. Okay, so that's how we know that's a patient cause. All right, so and then we'll look at this one. This one's a medial whip. Okay, it's kind of like Ronaldo in soccer. He's trying to do medial whips all the time to do his step overs. All right. So we are there, hour and 15. I've gone a little bit longer than I normally would, but what I want to do is I want to just kind of show you how impressive amputees are. Okay. So I have got some super impressive amputees that I've worked with, and these are a few of my favorites. So I've got one recent one right now, who I've got with me. So this is one of my guys. This is Kevin. He gave me kind of permission to go over these things. Now, Kevin is a bilateral below knee. And then he's also, you can see here, he's lost his hand on his left and he's lost all of his fingers on his right. Okay. Now he had strep throat, ended up getting sepsis as a result of strep throat, went on pressors, and as a result ended up as a quad amputee. But within I think it was 18 months, this was him after going through prosthetic training, back behind his boat and wake surfing, and he's just unreal. Just such a inspiration. There's a ton of videos online of Kevin. So Kevin Breen, you can go and search him up. I actually did a podcast with Kevin. You can go and search that up. You could search Kevin Breen, Class to Clinic, and I actually did a podcast with him where we talked about his journey and various things. It's a really cool listen. But yeah, so that's Kevin. All right, and then I got another patient here. Okay, this guy, his goal was, as soon as he came into therapy, hockey player, and he was just like, Mark, whatever we're going to do, I want to be back playing hockey I want to be back playing for my rec team within 6 months. I was like, you might need to pick a new goal. But he was one of the most determined people I think I've ever met. And he, this is why amputees are my favorite, because they are just incredible. So this guy who's like, no, I'm going to do it. Got out, went and did it, and was just incredible. Okay. But out there, and he's back playing hockey now. He plays in a rec league with a bunch of his friends. So that's really super fun. All right. And then this one. All right. This is a guy I'm working with at the moment. Okay. Now, if you're on, all right, everyone get your phone out. All right, do me a favor real quick here. So this is a guy I'm working with, and he's documenting his journey on TikTok. Okay, so he's still a current patient right now, so I can't really talk about his story or anything like that. But if you follow him on TikTok, he talks about, or his mom talks about his story, and various things. So if you see here, go get your TikToks, go give this kid some love. Okay. There's his handle right there. Just go over there and follow him, and he's documenting his story. So go give him a follow, and it'll make his day. So watch this kid. All right. So amputees are the best. All right. They're so good. So everyone go grab your phone, open it up right now before you sign off. Go follow this kid. All right. He'll break your heart. When I came out of my eval with him, I just wanted to sit down and cry. All right. But this is the kind of thing as therapists, this is the things this is what we get to do as therapists. Okay. So you guys are really going through the roughest part of your career right now, is finishing school, finishing clinicals, getting ready for boards. It's all the kind of really tough parts. And then we get to go and help this kind of stuff. So it's such a incredible part of our career and a privilege that we get to do. So go and follow this kid. He'll be absolutely over the moon on when I see him next week. Like, I got all these followers. So that's kind of what I wanted to get. He doesn't have many followers right now. I'm just kind of wanted to use a platform to help him out a little bit. All right, sweet. And then share him with everyone as well. Go tell everyone else to follow him too. And watch back on his stories, but get some tissues. All right, so any more questions on the crash course? PTA crash course starts Monday, or PT crash course. Okay. So PT or PTA crash courses, and go from there. Let me get his username back up there. It's at the top here. So any more questions on PTA crash course? If you've got any additional questions, anything you want to see about the course, you can. How much is the crash course for PT? $199. So it's $199 to get in for the 3 weeks, and you can have full access to that. All right. All right. So if there's no more questions about the crash course, anything like that, thank you so much for, thank you so much for tuning in, hanging out with me for the last thing. Then you can go from there. All right. Okay. So let's go from there. Yeah. All right, guys. The video and the PowerPoint will be posted into the crash course page. So if you do sign up for the crash course, you'll see this right at the top, prosthetic buzz session. And we go from there. How long are the meetings? Monday through Thursday. The crash course sessions usually last about an hour, depending on the session, depending on questions, depending on the class size. All right. So if the class size is big, I think we had like 500 people in last July. So some of the sessions went over a little bit, but we tried to be really, really fast paced. Okay. The video will be posted. I'll post the video tonight, tomorrow. Yes, everything's recorded. So for the crash course, everything is recorded. So if you miss a session, you can watch it back. All the PowerPoints get posted. There's a Telegram app as well that you can kind of have some peer interaction with your fellow colleagues and all of those things. All right, another couple of questions. What courses do you recommend for international PTs, different syllabus? Would the crash course be appropriate? International PTs, I would recommend jumping into one of our premium classes. The pass rate for first time for international students is quite low. We teach different. It's just a different way of doing the test. So if you are a foreign trained student, I would highly recommend that you either sign up to the VIP class or the PT or PTA premium class. Okay. All right. Excellent, guys. Thank you so much. Head over to ptfinalexam.com to see more information about the courses, the other things we're offering. And we also have a podcast, the NPTE podcast. If you're not following the NPTE podcast, go follow that. There's about 76, 77 episodes over there going over content, questions related to the exam. Really, really good binge listen, especially if you're out on clinicals right now. So awesome. Thank you guys so much. Appreciate it. And we will hopefully see you in the class. All right. Good night.